Good morning and welcome to Psychological Professions Week 2025. It's fantastic to be here to welcome you to the beginning of this week with this session. My name's Adrian Whittington. I'm National Clinical Lead for Psychological Professions at NHS England. And during this week, we'll be celebrating the work of psychological professionals, the contribution that you are making to making things better for the public. And there'll be a series of events across the week that are being delivered by members of our networks across the regions. If you have a look at the Psychological Professions Network website, you'll see details of all those other sessions. And you'll see a bit of a theme, which is that we're going to be focusing across the week on how the psychological professions can contribute to the three shifts in healthcare that are signalled in the 10-year health plan, and how we can move towards a system in which psychological healthcare is more embedded and central to the work of the NHS. So please enjoy the week. Today we're going to be kicking off with a session that looks in some detail at what the implications are of the 10-year health plan. So if we can go to the next slide, please. I'm going to encourage you, please, to use the Q&A function. So do post your questions and comments in there. The recording of this session will be made available afterwards, as will all of the slides. Next session, please. Next slide, please. Getting ahead of myself. So this is the plan for today. We're going to be welcoming Adrian James, Ali Bryant, Paul Edwards to contribute and start the session in a moment. I'm going to be taking you through some of the key opportunities and challenges as I see it in the 10-year health plan in relation to psychological healthcare. And then we'll have a Q&A panel towards the end of the session. So please do post your questions. We want to get to as many of those as possible. You'll see that there's the opportunity to uprate those questions, the ones that you think are most interesting and important. So please do that. And we'll seek to sort of make sure we pull out the themes in those most uprated questions. Next slide, please. So I'm delighted now to introduce Dr. Adrian James, who's National Medical Director for Mental Health and Neurodiversity at NHS England. It's been great working with Adrian since his time joining the organisation, and he's going to lead us off with some opening remarks. Over to you, Adrian.
Well, thanks so much, Adrian, and really delighted to be here, and thanks for inviting me. And it's great to be celebrating Psychological Professions Week and to be with you at the Psychological Professions Network. And I guess the first thing I really want to do is to thank all of you for the amazing work that you do day in, day out, often under very challenging but rewarding circumstances, all that you do for the people that we serve, and that's our patients. And just before I joined the call this morning, I was looking up the workforce census around psychological professionals, and it's really been quite staggering what's happened. I mean, your numbers in the NHS alone have doubled just in the last 5 years, and due to double again. And I think that's a sure sign of the great work that you're doing and the importance in which the NHS as a whole, and most importantly our patients, the importance that they hold this work. So where better to start than with the 10-year plan. And I think there is a huge amount of opportunity there for each and every one of us if we grasp it. Now, when the 10-year plan was published, we were told, don't search for the particular area that you're interested in. Of course, that's what everybody does straight away. So I searched for mental health, and mental health, in fact, is mentioned 59 times. So that's more than any other area, healthcare area. And it's throughout the document. So it's not just a section. Somebody thought we'd better say something about mental health. It's throughout the document. People are thinking of mental health. They're thinking about psychological well-being in all aspects of how the NHS operates. So I think that's a really positive sign. No, I've mentioned those figures. I'm not included in those figures as a psychological practitioner, but I trained years ago in cognitive analytical therapy. I'm sure there are people on the call today who are trained, and I always thought that was just a fantastic way of bringing different aspects of psychological therapy together. And I was actually trained by Tony Ryle, who was the founder of it, and he worked in Lambeth, as some of you would know. And there were some really interesting things concepts he brought in, that it was unfashionable in those days to do time-limited psychological therapies. Clearly, there are times when we do need very extended psychological therapies, and really important we recognise that for those who've got complex needs. But he really promoted the idea that it's possible to have time-limited, focused work, both combining cognitive therapy and analytical therapy. And he also introduced the concept of outcome measures, again, quite controversial, really. But I think the psychological therapists have gone way ahead of the rest of medicine, certainly the rest of mental health, in terms of the importance of outcome measures. And of course, that really matters to our patients, what they're trying to achieve through their therapy. So you have been part of a huge explosion in numbers, but more importantly, the quality of the work that you do, and really being at the forefront of those concepts that are so important now and will be going forward. So what about the 10-year plan? What does it mean for all of us? Well, within the 10-year plan, it does say that the psychological therapies program will be extended, and it's really important that it does, and not only within the mental health world, but really across the whole of medicine. So if something isn't in the 10-year plan, it's going to be very difficult to get a focus on it, but it's in there. So I think there's a sure sign that there will be further expansion, not only in numbers, but in the areas where people work. And we know that many of the psychological therapies, the numbers of people who are benefiting has increased hugely, but more work does need to be done to expand the number of areas where psychological therapies go. For example, older adults tend not to receive therapy so much. People from minority ethnic communities, again, we haven't done enough to make psychological therapies really sort of accessible to individuals and culturally appropriate. I know there's fantastic work going on in that area, but we all need to learn from that. And for example, in the important area of substance use disorder, we need to move mainstream psychological therapies into that area, because it's such an important area. I think as important of all those other things, a more psychologically minded NHS, and that's really important, particularly in our workforce. If we don't have a psychologically healthy workforce with good workforce well-being, it's very difficult for us to provide the best care for our patients. And we know that the higher the morale is, the more our workforce feel engaged in the work that they do, the more they get out of it, the better they do for patients. So it's not a selfish thing looking after the workforce, it's also about good patient care. It's going to be my privilege to chair the Modern Service Framework for Severe and Enduring Mental Illness, and that's going to cover all ages. I mean, primarily focusing on 16 to 64, but actually it'll go all age where that's appropriate, and focusing on psychosis, so bipolar and schizophrenia, eating disorder, and those with complex emotional needs. So there'll be work streams around all of those, and the psychological therapy engagement with that is going to be absolutely crucial to make sure that we can do the best for our patients. But it's not only for the Modern Service Framework in the mental health field, and there'll be another one in frailty and dementia, but actually across the whole of medicine. So there'll be one for cancer, one for sepsis, and one for cardiovascular. And again, we know there's fantastic work, fantastic evidence base around psychological therapies for those with a number of physical health conditions. We know that if we treat the co-occurring psychological issues, then obviously their mental health improves, but also their physical health improves as well. One of the things that I'm really keen to focus on is fidelity to the evidence, to really go back to the basics of what the evidence tells us about what works for patients. And clearly everybody's an individual. We need to make sure that we tailor therapy for the person who's in front of us. But there is a huge evidence base around the therapies that you all provide, and making sure that we always have a focus on that and we don't drift too much from that. And again, Psychological Therapies Programme has done a huge amount of work on ensuring that the training is right, that people are actually applying the therapy in the way that the training points you in terms of the evidence. And finally, in terms of neighbourhood health, this is the big shift from hospital to community, as well as the other shifts. We've already mentioned the shift from analog to digital. Again, we know that many of the therapies, that there is an evidence-based digital component. Not too much evidence at the moment around digital-only therapies, but that sort of adjunct to therapy. Again, NICE have approved 6 adjuncts, as you all know, but also the digital around pre-assessment screening, outcome measures, feedback. Digital isn't just about the core therapy, it's actually about all the things that are really important to make sure that we're delivering the very best. So digital prevention, moving from treatment to prevention. Again, a lot of the psychological therapies work, you know, is around prevention, around making people psychologically healthy, not only psychologically healthy organisations, but individuals, and resilience within organisations, but individuals. So the prevention is important there, and early intervention. But that neighbourhood shift from hospital to community, that's where most of the work that you do takes place. And we've got an awful lot that we can show the rest of the system around how best to do that. And I think one of the biggest shifts has been in the 10-year plan, or trying to get away from us designing a roadmap for patients to seek help. This is where you can get your help. This is how you guide yourself around the system, moving from really a roadmap from all of us, the people that serve our patients, to say, well, where do patients go? Where do they present? Is it in the high street? Is it to their GP? Is it to the emergency department? Where they're presenting, we need to be there and get hold of people and make sure that we can move them to a place where they can get the treatment that they need, and make it as close to home as possible, because that's where people want their treatment. And of course, many people want their treatment online now, but I think most of us would feel that that should be a choice, and that we need to have a blended approach. And many patients welcome a one-to-one assessment face-to-face, but then a lot of digital work as well. It works for everybody. So I think there's huge opportunities. I know that you're all up for change. I mean, to say, look at the changes that have happened in psychological therapies in the last 10 years. I think it's been really quite remarkable. So thank you for that. Thank you for being on this journey going forward. I think it's a really exciting time, and I look forward to working with you all to bring about what we're all here for, and that's improving the care for our patients. Thank you very much.
Thank you so much, Adrian, and thanks for being such a huge ally and advocate for psychological professions and psychological practice. It's fantastic to hear your thoughts about the expansion journey that we're on. It has been huge, and although we don't know what's coming next, I think we can expect that psychological professions will be a significantly important part of the next phase of development. So it's great to hear your thoughts on that, and the need for psychologically minded healthcare more widely, and for us to remain aligned to evidence-based and all the opportunities around neighbourhood. I'm sure we'll get stuck in more to all of those themes that you've raised with the great start that you've given us to the session. I hope you'll be able to stay around for our Q&A panel towards the end, so if anyone's got any questions for you, they can pop those into the Q&A. Thank you very much. So I'm delighted now to welcome our next speakers, who are Ali Bryant and Paul Edwards. And Ali and Paul have been working with us in the National Psychological Professions Programme and also in our sort of regional psychological professions network teams for some years now. And it's fantastic that you're able to join us, because we want to put your voices and thoughts, in other words, the voices and thoughts of members of the public, people who might use services, at the heart of how we engage with this next phase of change. So you've just got a sort of small topic here, which is what we think. So over to you both.
Oh,
Thank you.
Thank you so much, Adrian and Adrian, for what you've already spoken to this morning. But Paul, just hand over to you.
Thank you so much. And just introducing Ali. She's a wonderful person with lived experience of both physical and mental health experience, as both myself as well. So next slide, please. So yeah, just to say, what do we think? What is our views? But this has a real big caveat to it. Isn't just our personal views. We spend a lot of time talking with other people, both who are already in care, both physical and mental health, but also outside of that who haven't managed to reach out yet. So we have got those views, and we are proud in saying that we do collate a lot of information from other people, because two people's voices is not worth anything. So we caveat our conversation with that. And firstly, I'd just like to thank everybody, and echoing Adrian James's words. Thank you from a patient's perspective on how hard you all work. We know the challenges you have. We're not ideological in as much that we know that you haven't got challenges yourselves, but it is a vocation, and we are very proud of all of you for helping all those people in those lives struggling with their mental and physical health. Next slide, please. So we just wanted to first start off with a slide that we're not going to really speak to it, but I think everybody can see how the fact that there's a very fragmented healthcare system at present, and the fact that we don't feel that as a patient we are fully understood. And as Adrian James said, where do we reach out? And as you can see here, we're quite grey in our thinking, and where we see it at the moment. We have a lot of work we have to do ourselves. We understand that, and but we think it can be far better. We'll just take the slides off. We're now going to just talk about the 3 shifts. So first and foremost, when we were reading the 10-year plan, I was noting that the Darcy report mentions the diabetic pathway, and fortunately for me, I got diagnosed with diabetes early in the year. And I say fortunately because it was really a wake-up call, and I had 2 choices. I had a choice of, do I sort it out with diet and by talking to the diabetic nurse and the other departments, or do I just rely on medication again? And I decided to be proactive about it. And I thought about how this can actually work as well with other mental health. So why are we not introducing, when people have got severe physical problems, i.e. oncology departments and long-term conditions, why don't we not hit them with prevention at that first point? And it's something that we got thinking about, myself and Ali. My diagnosis of diabetes was quite a shock, but I was very pleased when the nurse asked me how it had affected me mentally, and was there anything that she could do with assisting with how that was going to help. And I took that as a real positive, as to the fact that we were becoming more psychologically aware in the NHS. And also, when I've changed my diet, I've found out it has changed some of the long-term conditions that I've had, and it has had a real positive effect of that. So for me, that it's been a real wake-up call to understand how the diabetes pathway has worked. But thinking about more, Ali, how would you have a perspective on how it can help you and how it can help others in the future?
Yeah,
and going from sickness to prevention.
Yeah, I think you've kind of spoken to that in terms of your journey that you've just shared. It's how the system changing going forward with the 3 shifts can help us all to be active partners in our own care, in our own trajectory, in our own journey. So, I do have a question mark around my ability though to always step up, and I think that's around where psychologically informed care can really add benefit to somebody like me and like you. I have multiple long-term rare conditions, and that's alongside long-term mental health conditions too. So I know I've had experience, in that greyed out slide that we've showed, when, kind of psychologically informed care has either been present or it's not been present. And that is so important for me to own my own healthcare journey. We all want, like, the NHS to be fit for the future, but, how do we do that when we live with those complex conditions? I know how important, and I can really say this is so true, early intervention and access to support to prevent escalation is absolutely key. And, for all patients, whatever your diagnosis, whatever your issues that you're presenting with. So, whether that's preventing the development of multiple long-term conditions, by supporting children and young people much earlier in the lifespan to have that better life and better outcome, that I know certainly for myself with very long-term issues, that I would have had a different life trajectory if that had been present. So that supports better outcomes. So yeah, I think the consequences when mental health is unsupported in healthcare, are well known and understood, and that's really threaded into the 10-year health plan. My emotional well-being, if that suffers and I have that uptick in anxiety and panic, then really, how do I start to begin to address my physical health issues? And it's really having a team that really asks you those questions in conversation means everything to be able to really take this information on board in how to own your care. As you spoke to, Paul, in terms of, you went forward, you had those conversations with the diabetic nurse, that has really changed the trajectory of how you are living with diabetes and knowing that you're improving your health as a result. And, we've spoken, and I know Adrian did as well, about the pathways, re-cancer and cardiac care being successful and well established. But, this is what the 10-year is doing, and that's what gives me hope about building on that model for the other conditions and specialisms to have those improved patient outcomes. I really hope the 10-year plan will support patient well-being with those prevention strategies, with a holistic lens to help patients stay well and in better health for longer, with better training.
On that, then, interestingly, and I'm just kind of reflecting on the fact that what you're saying, and I think that really nicely ties in, Ali, to the hospital to community, and what you're speaking to about how you can access that care more easily, and we know that the neighbourhood practices are coming in, and there was initially 6 coming, and I think there's been an announcement there's another 43 coming in, really. But what challenges have we got from a patient's perspective regarding those? And what I'm thinking about is not only the how to reach out, but also the sharing of information from the mental health perspective to those physical care settings. And how can that be positive, but also how could that be dangerous?
Really for me, the shift from hospital to community is absolutely key. And that really brings person-centred care back to people closer to their homes, closer to their friends and family that support them living with, their physical health or mental health needs. So really, I suppose for me, the real positives are around that shift, bringing things back to local, but obviously there are risks. We want to know that those all those staff that are supporting that shift have that psychologically informed stance, that's been built into their training and built into the delivery of that shift. That's really important because that's key for me as a patient. But I guess, that's that sense of holistic care, being aware of social determinants of health equity, making every person in every community welcome into that space are really going to be very important in the delivery. But I do have issues around particularly the single patient record. Now, and it's contradictory as well, because the single patient record for me is a way of unifying care, not repeating information, but I do have concerns. And so recently, for example, thinking about my mental health records, and I'm very sensitive to the content that's involved in my mental health records, and traditionally within therapy I'm asked what I would like to be shared, for example, with a GP in an overview, so I give my consent to that. But I had a hospital appointment, an outpatient appointment, where the type of questions that and answers that I had to give really replicated what happens in the therapeutic space. Many weeks later, I opened an envelope that came through the door to find extremely detailed, highly personal, traumatic information detailed within that letter that was shared with me and with the GP. It wasn't mentioned that this information would be broadly shared. I had been really shocked to see that I had no sense and no opportunity to consent to that information being shared more widely. So I do have concerns about what is shared, how it's shared, and what measures are going to be put in place to ensure that consent happens for patients. But as I say, that's also completely contradictory, because for my physical healthcare records, of course I want them shared. I want the workforce to have access to things that will support them in my care, and I want to know that my care is going to be better because of the single patient record. So it's a bit of a conundrum, really.
It is, and obviously, you know, the move from analog to digital is going to include a lot of things like that. But again, this has to be about patient choice. Mm-hmm. Everybody should be asked which parts of their mental health records are shared, with whom, because as you say, it can be very dangerous. And for me, you know, speaking to people outside, that they wouldn't share a lot. But very quickly, because this time has moved on and we've got a short amount of time left, just let's touch on the benefits of digital over analog, but also the fact that, again, patient choice. And I know you've been doing some work in digital, but to do with research, which fascinated me. And I just wonder if you could touch on that for a couple of minutes.
Yeah, sure. I think that the shift kind of going forward from analog to digital is really going to support the workforce. It's going to support the workforce, and it's going to support patients in the way that they're supported maybe around appointment times. So, you know, apps and innovations to support the digital future and how the 10-year plan is delivered. I'm lucky to be able to use, as you've said, my lived experience in research, where I've seen those exciting innovations which are spoken about, but I've seen them behind the scenes in practice. So journey mapping, PROMs, robotics in surgery, mental health avatar and wearables, which I'm really excited about because I think they can be hugely supported and help to deliver new patient care pathways. But the sense check for me is really around, are they psychologically informed? And that's why it's important that, you know, people who are service users like us get involved in research to make sure that that component of delivery is rolled out as we would wish to see. So at the Mental Health Research for Innovation Centre in Liverpool, you know, I am working with the research team to develop those person-centred mental health innovations with those future service users and the workforce in mind. I think that use of digital will offer an additional layer of support for the future, as long as it's personalised, because what digital will never replace is the therapeutic alliance. We both know how transformational that can be. It's being listened to and being heard, and the psychological professions, nothing else can replicate.
And if we can just have the next slide, we move on to what our vision would like to be to the future. So from this grey fragmented thing to where we think it can go. And Ali's just got a few words to finish off with.
Yeah, both Paul and I have really we are so inspired by the psychological professions. The psychological professions have been so important to us, and they're key in the delivery of the 10-year plan, and making all health and care psychologically informed. So please listen with us now to some other voices that speak to why talking therapies and the psychological professions are vital to the health of all of us.
Next slide.
Help. I need somebody.
Help. Not just anybody.
Help.
You know I need someone.
Help.
I've never needed anybody's help in any way.
But now these days are gone, I'm not so self-assured.
Every now and then, I feel so insecure.
Help me if you can. I'm feeling down.
And I do appreciate you being around. Help me get my feet
Back on the ground.
We all need help sometimes.
Feelings of anxiety and depression can affect anyone. The NHS is here to help.
If you need help with your mental health,
You can refer yourself.
Or your GP
Can refer you.
let us help you get your feet back.
back on the ground.
Go to nhs.uk/help.
Thank you so much, Ali and Paul, for that fantastic overview of what you think about the kind of next stage of developments. And I was really inspired actually to hear your perspective on the potential fragmentation that is experienced by everyone who uses the health service, fragmentation of services, things not being connected in an optimal way. And sort of your alternative vision for this kind of integrated psychological thinking at the heart of a certain neighbourhood approach, I think is really inspiring. And patient choice and the views of the public being central to all of that. And I think your contribution today really reminds us of that. And we want to carry that in our hearts as we go forward in this next stage of the development of the NHS. Thank you very much. And we did spot that you had lovely little, so they weren't quite avatars. Maybe next time they'll be speaking, but little logos of yourselves in that final slide was fantastic.
I've got to thank my son for that, who actually produced the PowerPoint whilst he was waiting for an operation on his ACL and was actually in a hospital bed. So thanks to my son for that.
Thanks, Joe.
You. And we look forward to you joining us on the panel towards the end of the session. Thank you. So if we can go to the next slide, please. I'm going to be now delving into the 10-year health plan and some of the opportunities and challenges that I think it presents us with as psychological professionals, particularly in the context of this sort of broader landscape that Adrian's described, that Ali and Paul have described from their different perspectives. We go to the next slide. What I'm planning to cover is threefold. Why we need a new care model, what's in the 10-year health plan and the opportunities and challenges that presents, particularly for psychological healthcare, and what next for psychological healthcare on the basis of that. Next slide, please. So why a new care model? Well, really the most important reason why we need a new care model is for all of the reasons that Ali and Paul have just outlined, that we need a service that works as well as it possibly can for the people using it. And there are some really significant issues with that at the moment that need to be addressed, and some real great opportunities to move that forward in a new direction at this time of change. But there's another reason why we need a new care model, which you'll see is absolutely central to the work that led up to and then is integrated in the 10-year health plan. And that is the challenge of the gap between demand and capacity. And so if we go to the next slide, the Darzi review is an independent review of health services that was published in September 24, so not long after the current government came into power. And it was commissioned by the government to look at what are the issues facing health going forward. And it really is striking, the kind of conclusions that Lord Darcy drew, that there is a fundamental challenge. We have a demographic challenge that is facing us in the provision of health services. One aspect of that is life expectancy, which has continued to rise over the previous decades. We see a little blip there with it falling during the period of the pandemic, but on the rise again now. So we're getting older as a population. That's what the left-hand graph shows. On the right-hand graph, you'll see that as we get older, the chances of us experiencing long-term health conditions significantly increases. In fact, if you're in your 40s, you've got something like a 30% chance of having a health condition, a long-term health condition. If you're 85 or older, you're sort of 85% of us will have 5 or more long-term health conditions. And unfortunately, although we're getting older as a population, we're not staying healthy for longer as a population. We're staying healthy for roughly the same period of time into our 60s on average, but as you see, that as we get into older age, those long-term conditions really significantly increase. So we're managing increasing numbers of long-term chronic conditions as a population. What's interesting, if we go to the next slide, is that on the left-hand side, and you may find this slightly hard to read, the writing's small. If you look carefully, you'll see that, yes, there's been this sort of really significant rise in chronic conditions such as hypertension, diabetes, which have a very significant impact on services and our ability to meet those needs. It's great to hear from Paul that your recent experience around diabetes was a positive one on the whole. But if you look at the lines that I've highlighted here, where we've seen the really dramatic rises in prevalence is in mental health conditions. So here showing anxiety and depression really rapidly on the rise over the last decade. And there's obviously a debate in the sort of public narrative at the moment about, is there too much diagnosis going on? Well, if you look at the Adult Psychiatric Morbidity Survey, which is based not on diagnosis, but on experiences of the symptoms of mental health conditions, you'll see that those symptoms are definitely on the rise and have been for some years. And that has a sort of follow-on impact. So the example on the right-hand side of this slide is children's mental health services. And you'll see that, in fact, over the last sort of 15 to 20 years, there's been a trebling of demand for children and young people with mental health services, which I think reflects some of these changes that we're seeing. So there's clearly a sort of really significant issue facing us now, but also into the future, about the growth in demand for services and the fact that we're struggling to provide the capacity to meet that demand using the traditional care models that we've had. And that's why Lord Darcy really sort of landed on that we need to do something different. And if we go to the next slide, he started to signal these 3 shifts that we've already been hearing about today: treatment to prevention, hospital to community, and analog to digital. And really, as a sort of in large part as a way of seeking to close that gap between demand and capacity. And so rather than only focusing on increasing capacity, to also focus on reducing demand. And these shifts have a lot to say about reducing demand and managing demand in a different way. So I think this does lead us into a period of sort of radical change, and that actually gives some opportunities, which will sort of thread through the rest of this session. Because this isn't just an opportunity to manage demand and capacity differently, it's an opportunity to use this change, this shift, to also serve the public better in some of the ways that Ali and Paul have outlined. And of course, there are some risks in these sort of dynamic, changeable ways of working as well that we'll need to attend to. I thought it was a great example that Ali and Paul gave about the sort of shared digital record and some of the risks around that absolutely need to be attended to. We need to get it right. So if we go to the next slide. So I'll focus in now a bit on what the plan says. just in case you haven't read every page of it, and some of the opportunities and challenges in there. And I'm going to pick out some of the specific things along the way that are relevant to psychological practice, psychological professions, and many of us, of course, work in mental health, and so some of the sort of content will be particularly focused around that, but I absolutely recognise the role of psychological professionals across the whole of health and care. So if we go to the next slide. The plan was published in July of this year. It's really it's called a plan. I would say it's a strategic vision. It sets a direction. We don't yet know exactly how all of the sort of direction will be enacted through plans, but we're starting to see some of those plans come through now. Next slide, please. So this wasn't something produced entirely in isolation. It was a plan that was informed by actually 250,000 contributions from members of the public, ourselves in sort of being practitioners in the service. And I know that a large number of psychological professionals also contributed. And it draws a really stark conclusion, which is the NHS stands at an existential brink. So it's really sort of upping the ante in needing to change. In fact, the title of the first chapter is "It's Change or Bust. We choose change." So it sets us a real challenge, and the change that is being proposed in the plan is an entirely new way of organising services, a new model of care. I know we'll bring back the slides as soon as we can. Thank you. And within the plan, there's also a sort of significant emphasis on a goal of narrowing health inequalities. This was also something that Lord Darzi really demonstrated in his independent review as well, that we remain a society that has massive health inequalities and that we need our services to address those. So I'm going to come on to hospital to community as a first shift. In fact, the next 3 chapters of the plan are organised around those 3 shifts that we've already heard about. Yay, we're back to the slides. Thank you. So what's this shift all about? It's all about taking the service away from a service that is primarily organised around acute episodes of physical health problems, illness, sickness, delivered by hospitals, and shifting much more towards a neighbourhood-focused approach that moves more of that care closer to home and out of hospital. And of course, looking at that data around prevalence, etc., we can see why, because really we're facing a sort of situation in which far more of us are going to be sort of dealing with chronic health conditions that have a sort of significant duration across our part of our lifespan, rather than what the NHS was originally designed for, which was largely acute episodes of sickness. And we can see the implications of that. I'm sure many of us have sort of experiences of that in our own families, of relatives and going into sort of hospital. Really what's needed is a much more sort of holistic approach, but what the hospital can do is treat an acute episode of sickness and then try and discharge someone out to the community again. If we could manage more of that in community neighbourhood settings, then of course we could start to sort of provide a service that is much more holistic and delivering for the public in a different way, but also move some of that resource out of hospital care and deliver it in ways that are sort of more efficient. So there's 3 elements in this part of the plan that are particularly significant, I think, for psychological practice. The core element is the development of neighbourhood health centres. And these are sort of health centres that will deliver more healthcare closer to home across physical health, but also, mental health is mentioned in relation to these. And it's really important we make sure that psychological practice, both for mental health and to support physical healthcare, are embedded in that new neighbourhood way of working. But there's also some specific mentions around mental health. So there's a mention in the plan of neighbourhood mental health hubs that are open 24/7, Some of you will be working in those hubs. There's 6 currently trialling. I was really inspired actually to attend a meeting of the psychological professionals working in those pilot sites last week, and to see some of the great work that's happening there. There's also a commitment to 85 new mental health emergency departments. So the idea of these being to make the emergency response to people with mental health crises more appropriate than it's currently possible to deliver in regular emergency department settings. So some of those will be integrated parts of emergency departments, others will be delivered in a slightly different way outside of the ED, I think. Next slide, please. So the second shift that has a chapter of its own is analog to digital. And if you read the plan, I think you'll get the sense that this really is a huge push that we're now starting to experience. A lot of the things I'm being pulled into now in my national role are related to digital. There's going to be a massive emphasis on this, and I think it is being seen as a really significant part of the next phase. And part of this that's mentioned in the plan is the NHS app becoming a digital front door for all services. I think NHS talking therapies are being seen as a front runner in this, and the opportunity for the app to drive that front door, but I think it will come across all services as well in time. And signalling of a health store, which will also provide digital mental health apps through that sort of central portal. And so there's a lot of work going on to understand how that would need to happen, and what some of the how we remain true to that element that Adrian was talking about in his introduction around evidence base. Next slide, please. Sickness to prevention. This is the third shift. It has a chapter of its own, and I think it's fair to say a lot of the action here is probably going to be in areas that aren't actually the domain of the NHS. So things like smoke-free generation legislation, action to change the rules around advertising of foods, to tackle obesity. There's also going to be a big push, we think, on genomic testing and what that can do to help prevent and foresee health conditions that can then be tackled earlier. But there's also a focus in this part on social determinants, and rightly so. So of course poor health is linked to unemployment, to debt, to other sort of aspects of living conditions, poverty, and that absolutely needs to be part of this push. But this is a cross-department governmental endeavour. These clearly can't all be the responsibility of health services. But I think this shift does also lean into sort of early intervention. So it's not just about primary prevention, preventing illness in the first place, but it's also about intervening early. And there's a significant component here on completing the expansion of our mental health support teams in schools, which is obviously a really significant endeavour led by psychological professionals and staffed by psychological professionals. There's also a sort of commitment to Young Futures hubs being a kind of community delivered resource for children and young people that also delivers psychological interventions. So some significant early intervention components there. Next slide, please. So those shift chapters aren't the only chapters. There's 9 chapters in the plan, and I'm not going to go through all of these in detail, but I think it is worth picking out some of the other strands that really strike an important note of what's coming. So the new operating model for the NHS is set out here, and we do see a shift away from its sort of current ways of working, and obviously to a new system in which there will be a centre, which will be a sort of integrated, what is now NHS England and Department of Health and Social Care. There'll be a regional office footprint for that sort of central function, and that's going to be really responsible for managing and supporting quality of delivery by providers, as well as some other aspects like education commissioning. Integrated care boards will still exist, but will be leaning much more towards their strategic commissioning function rather than broader functions that they've had previously. And providers will have increasing autonomy where they perform well to sort of deliver against all of these agendas that are in the plan. There's an important strand in the quality of care chapter around patient voice being at the heart of everything we do. That's really important to us. But also significantly in this chapter and radically, there's a commitment to all services reporting on patient-reported outcome measures by 2029. That's all services, all mental health services, all physical health services. And we've yet to see exactly how that will come to pass, but it's a very important commitment. Modern service frameworks Adrian has referred to in his introduction, and this will also be a sort of significant strand setting out the kind of good, the vision of best quality service to drive our services forward in the specific strands that are being focused on. So severe and enduring mental illness being one of those, but also the others that Adrian mentioned. Workforce, there's going to be a 10-year workforce plan. I'll say more about that in a moment. There's also a commitment to staff treatment hubs for NHS staff. So those of you who were involved in the delivery of the sort of resilience hubs during the pandemic, this is welcome news because the staff treatment hubs have a particular focus on musculoskeletal and mental well-being. So there's a role for psychological professionals there. Chapter 8 signals some of the, tech-based transformation that's coming down the track, AI, genomics, wearables, absolutely right that we're focused on those things. And then the final chapter, this may be where, if you're a clinician working in service, you think that chapter's not for me, but I think you will be experiencing in various different ways the transformation that is outlined here, and particularly the eradication of deficits. So there's a very strong push towards services no longer ever running a deficit. And this really is an entirely new and unprecedented position for services. And that is what many of you will be experiencing in things like difficulty releasing jobs for advert and that sort of thing. That's all about managing deficits. So multi-year planning also appears in that final chapter, and that's really important because that will allow us to look forward, and I'll say a bit more about that in a moment. And reallocation of resource from hospital to community, also signalled here strongly. Next slide, please. So I'm going to just dig in now to what I see as some of the key opportunities around psychological healthcare that are presented by the plan. And of course, you may have your own interpretations of this and focus on other areas, but I wanted to focus on these three. So psychological approaches in neighbourhood healthcare. I think we have a great opportunity here in this shift from hospital to community, in thinking about neighbourhood as the fundamental sort of approach to healthcare. What we can't do is just allow the existing system, which is focused largely around acute episodes of sickness, to just transfer into a different footprint in a neighbourhood. A neighbourhood is a population, by the way, of about 60,000 people, so it's a very small unit. And what we perhaps have an opportunity to do here is to, at the same time as that shift, really shift towards a truly biopsychosocial approach to healthcare, because that's what's going to be needed. That's what's going to be needed to manage long-term conditions, to provide psychological intervention and support around a whole range of health conditions, physical and mental. Next, please. If there's an example that I'd like to give you. This is Dawn, who is a psychological wellbeing practitioner who works in the Somerset NHS Foundation Trust in the stroke rehabilitation pathway. And the project that Dawn's been undertaking there has been really significant in, I think, demonstrating an example of how you might really embed psychological practice into a kind of neighbourhood-based way of working that helps people manage long-term conditions. So I think we need to do more of this. What Dawn's been able to do is work with people in recovery from stroke to support their psychological well-being, getting back to where they want to be, and supporting their recovery, and at all the time in doing that being able to demonstrate outcomes that have allowed the project to continue. Digital innovation. We've got an opportunity here, I think, to be amongst the leaders of digital innovation in this next phase. And the reason I say that is that as psychological professionals, we've led on and started to implement recommended evidence-based digitally enabled therapeutics that support people's psychological health. That's a really significant contribution we can make at this time. Next, please. The example I'll give of this is the work, there's many examples, but the example I would give is the work of Dan Freeman in developing the Game Change intervention for psychosis. This is a virtual reality intervention where people who have psychosis or at risk of psychosis interact with virtual avatars and environments to help them overcome anxiety and avoidance. And this is an intervention that is recommended for further evaluation by NICE in the early evaluation, early value assessment. And it's a great example, I think, of how we've got to a point where we do have digitally enabled treatments that are known to be likely to be helping people, and they need to be taken into implementation in order to fully evaluate them further in practice. We can really lead in this area. And the third opportunity, I think, is that sort of radical promise that is in page 88 of the 10-year health plan to universal outcome reporting. And the reason why this is so sort of significant is that I think, as Adrian actually referred to in his introduction, psychological professionals have been amongst the leaders in this, and we can continue to contribute that leadership to taking this forward and making sure that we're evaluating the right sorts of outcomes to really focus on what matters to the public, as well as to support getting our work right as we work with people directly. Next, please. And the example I would give here is the work that's happened in NHS talking therapies to, from the get-go, report publicly on patient-reported outcomes. The graph that you can just see here shows that when we started NHS talking therapies, we didn't start delivering outcomes at the level that you might expect. It actually took a number of years to reach the recovery target that was set for the programme at the outset, which is 50% recovery. You can see that the recovery outcomes crossed that line in about 2016. And I think what this demonstrates is that where you can get really sort of universal outcome reporting, it can both help to drive improvements in the service that make life better for the people using it, but it can also drive investment in that service. And I think using outcomes, leading the way on this for psychological professionals will be very good for us and the public, in that it will help to drive that future focus and investment. I think it will show us in good light because it will show the impact that we're making. Thank you. Next slide, please. But there are some challenges and some risks, and Ali and Paul have mentioned some of these. These are some that I would pull out. So the first being, when we enter a time, which we may be, where we've had really significant rapid growth, but now we're sort of changing again towards trying to operate a different care model, and this different care model may not involve such rapid growth. And we know there are real challenges for those of you working in services around sort of capacity demand on the ground, and challenges with sort of releasing monies for making sure we fill our vacant posts and all of those sorts of things. At times like that, when there are those challenges around resources, it's going to be really important that we don't revert to a situation that I think we were more in about 10 years ago, where we were competing amongst ourselves as psychological professionals. Next, please. And you'll recall that, of course, in 2020, 2021, we ran this process called Psychological Professions into Action. We arrived at a set of shared commitments for the psychological professionals to make a difference to the public, that are signified here in the planets, in the vision. This is still really relevant because I think it binds us together in a shared set of values, a shared set of commitments, and helps us remember that we're working together to try and create this more psychological NHS, rather than reverting to a situation where we're more likely to all shout for ourselves and our own piece. So I think that's really important, that we continue that shared voice and that shared approach. The next challenge is, how do we get into the conversations? And the answer is, we need to be proactive, sharpen your elbows. Next, please. There's a risk, I think, at these times of big change, that the big voices get heard more than the smaller voices. And like it or not, with 34,000 whole-time equivalent professionals in the service, we are one of the smaller voices when you look at the NHS as a whole. And so it's really important that we punch above our weight and we're proactive in being heard and making sure that our work is seen and valued. It's great we have this week as part of that process. But if you aren't already a member of the Psychological Professions Network, I would really recommend that you join it in your region. We have 7 regional networks. They're really key in bringing us together, ensuring that those voices are heard and joined up and connected with policy. And so please do get involved. It's a chance for you to have your voice heard and to be connected in with what's happening. Next, please. So the final area of challenge, I think, is, in a way, the biggest risk is that we don't change enough. If it's the case that the NHS is an existential brink, we really need to make this change to put it on a good footing to go forward. And I have a lot of sympathy with that view, and I think we're actually pretty good at embracing change as psychological professionals. We've changed a huge amount over the past 10 years or so, and I think we need to continue to embrace that change. And an example of this is really supporting the work of the mental health support teams, these teams that are supporting young people with mental health challenges in school and college. In this picture are Julie, an education mental health practitioner, and Sam, who's a young person who's been working with her and in Hull. And just fantastic to hear of the work of these teams, how this has started to transform the lives of many, many young people who are receiving that service. There are now 700 teams, I understand. But that's due to complete so that there will be access to those services from every school and college by 2029. So these are just examples. Obviously, I could have drawn out hundreds of different types of examples, but these are some examples that I think illustrate the sort of key opportunities and challenges from my perspective. So what next? Next slide, please. Well, I think there's a number of strands now that are sort of starting to drop out beyond the 10-year health plan that are starting to drive what will happen next. It's all thematically aligned and consistent on the whole. So if we go to the next slide, the first of these strands is, and you'll recall in the 10-year plan, I said there was a commitment to longer-term, medium-term planning, so multi-year planning. And we now have the first of these multi-year plans, which is called the medium-term planning framework. And in case this hasn't crossed your path yet, I'd recommend that you do gain an awareness of it, because it will shape the priorities of the next 3 years as delivered by providers. And you'll see in the objectives of the planning framework some very clear directions of travel to reduce waiting times, to restore access to local care, in other words, improve the ability to get appointments, cut unnecessary bureaucracy, and enable local leadership. Well, I think for all of us, whatever role we're in, we can exert some local leadership. So I would invite you to do that, please get into the conversations about how your service is delivering on this and how it's reporting on the medium-term planning. And it's a bit like Adrian said about the 10-year health plan. There's a tendency for us to read these sorts of frameworks and documents for are we mentioned specifically. And of course, a planning framework like this sets out priorities. These are the priorities for every service to deliver on over the next 3 years. And all of the work that everyone on this call is doing is really important, but it can't all be mentioned in the planning framework. What, however, I think is really positive is that we have a number of strands that are specifically mentioned and specifically committed to that are about psychological healthcare. And we should absolutely, whatever strand we work in, if it's not one of these, we should take pride in the fact and value from the fact that psychological practice is strongly mentioned. So we have in the plan that commitment to the full rollout of the mental health support teams. We have a specific set of targets around NHS talking therapies expansion and continued improvement. We have the need for all mental health practitioners to align to the Staying Safe from Suicide guidance, which is of course a formulation-based approach, highly psychological. We have a commitment to acting on autism and ADHD assessment where the waits are far too long. In fact, we saw the report from the ADHD task force last week, which has a lot to say about this as well. And reducing admissions, particularly for autistic people and people with learning disabilities, another important strand. So lots for us to take forward using this plan. But if you look at it, you'll also see that there's the much broader pushes within it around neighbourhood that we can all be part of, around digital that we can all be part of. So please have a look at this. This is going to be an important strand in what comes next. Next slide, please. So we also have coming the 10-year workforce plan that was also signalled in the 10-year health plan. I think we can expect this to be a significant change of direction. You'll remember that we had a 10-year workforce plan just a couple of years ago, and here we are creating another one. And that's because this government want to take a really different approach to it, which is rather than asking how many staff do we need to maintain our current care model, it's asking a different question. Given our reform plan, in other words, 3 shifts, etc., and our commitment to a sustainable NHS, in other words, it's got to be affordable, what workforce do we need? And we're expecting this plan to come out in the spring. I think it may well still have growth in it. And in fact, the modelling that we've been doing around the existing policy commitments suggests that we do need to continue growth in the psychological professions. The modelling that we've done suggests that that is faster than any other group in mental health. We continue to need to grow. But it may be that that level of growth is less than it's been over the past 10 years. We don't know yet. We'll see what comes through. So that does signal a change. However, we have an opportunity to bring a great set of ingredients into this melting pot of what comes next. And if we go to the next slide, of course, we have our 21 plus occupations in the psychological professions. These are key ingredients that we have to contribute, all extremely valuable and important in the contribution they make. And equally important is what do we need to contribute? So these are some of the sort of pieces that we can contribute. But if we go to the next slide, I think as we're in this melting pot of change, it's really important that we remain focused on all of the areas of psychological practice that we value and that we know are important to patients and teams and services. So psychologically informed environments, this is, for example, the work that psychologists and others do to undertake team formulation or to support trauma-informed care in teams. Psychologically informed interventions, many of our different groups deliver psychologically informed interventions. These are the sort of, for example, a mental health and wellbeing practitioner might deliver graded exposure to support people's recovery from severe mental health problems. There are specific model-based psychological therapies, for example, what's delivered in NHS talking therapies, and they have particular governance systems around them, specific training, etc. And we have bespoke psychological practice, which is formulation-based. It might operate in a system in which there isn't nice guidance, or where we need to construct novel, new ways of working based on the specific, unique needs of an individual, family, service, or team. So we need to keep all of these quadrants in mind in going forward. We can't focus on just one of them, and where we do focus on one of these areas, it isn't to the exclusion of the others. We need to keep them all part of our picture. Next slide, please. So I'm coming towards a close. This is where we've been in terms of our growth. So we've grown by something like 125% since 2016, and that puts us now at a whole-time equivalent within our psychological professions of about 34,000. We may see a levelling of this temporarily. We may see further growth, but more targeted. But whatever happens from here, it's going to be so important that we remain focused on retaining the people who have joined our professions over this last period, and providing opportunities to progress both within existing occupations and on into other parts of the psychological professions family. Next slide, please. So, in a way, what you might have a sense of is that I think we're playing a game of three-dimensional chess. And the reason I use this metaphor is that, clearly there's different dimensions involved here. There's what the public needs, that's most important. There's what policy is saying and driving, which is also really important. And then there's what we as professionals can offer. And it's only by sort of bringing those three dimensions together into a meaningful whole that we can make the maximum possible difference that we can. And I think as psychological professionals, whatever our role, we can play a part in leading on this, informing the system, informing our teams about what can and can't work well. And in doing so, I think that leadership can make a big difference. If you want to read more about sort of leadership perspective at these times of great change, there's some excellent blogs coming out from some of our leaders in the psychological professions networks across the week. The first one's out today from Geeta Bhutani. So please have a read of those. I think if we can lead and drive this forward, we can be key players in supporting a truly more psychological health service for the future. Thank you very much. I'm going to stop there and I'm going to hand back to Naheem Akhtar, who's going to lead the panel Q&A.
Thank you, Adrian, and thank you to all the other presenters, Adrian, Ali, and Paul as well. As I'm sure you can see from the reactions from the audience, it was very informative and very welcome. Good morning, everyone. I'm Naheem Akhtar, Strategic Lead from the National Mental Health Team at NHS England. Good to have you all here, and thank you to everybody for posting your comments and your questions in the Q&A channel. So we really appreciate that. So without further ado, I can see we've got lots of questions. So we'll start going through some of those questions with the panel. And I just want to highlight, as presenters were presenting, we were keeping an eye on the questions coming through and kind of picked up a few themes that were coming in. So the panel might not have seen, but I think the move towards digital was kind of coming through in terms of how that's going to work, accessibility, integration, moving forward of services from how they currently sit now and what they might look into the future, and an element of the kind of workforce that's required or going to be required, and any kind of training and upskilling. So for me, those were some of the key themes that came up in the questions. So without further ado, we'll just go through some of the questions that came through. So the first one was around, this one's probably for, there's two Adrians on the panel, so I'll say Adrian Whittington and Adrian James. First one was around, the question was asked, I've been told that the significant increase of clinical psychology training places has now resulted in a vast number of newly qualified clinical psychologists struggling to find posts within the NHS. What is being done about this in relation to the 10-year plan?
Did you say that was for me, Naheem? Shall I kick off on that? Yeah. I mean, I've also heard talk of it being not as easy as it was to find jobs. And I think some of this, my reading of this is that some of this is temporary and is about sort of temporary freezes on recruitment, etc., as organisations try to balance their budgets. I think clinical psychologists, newly qualified and others, remain utterly essential to the work going forward. And interestingly, if you look at the sort of longer term data on this, we're not seeing a big move of clinical psychologists out of NHS practice. So although it's widely thought to be the case that there's quite a significant movement there, it doesn't seem to be any different, any change in that really over the last 15 years. So we are retaining clinical psychologists in the service. I think we might have a bit of a blip in the current recruitment processes that unfortunately are meaning some people are finding it harder to find jobs. Probably, I mean, what I've heard is also that people might be needing to, unlike some points in the past, apply for several jobs and not take their first choice.
Yeah, I think you asked if I could come in, Naheem, as well on that. And yes, I think this is true across many professions. I speak to GPs. There is a national shortage of GPs. People really could pretty well apply for any job that they wanted, really only going back at about 3 years ago. And I think there has been a squeeze across all jobs, all professions. And I think people will know that the numbers of people, for example, working in ICBs, in the local groups that plan and commission all our help services, there's a squeeze there. All provider organisations are being told that the sort of long established norm where not because they weren't trying, but organisations overspent year in, year out. People have been told that cannot happen again, and organisations must live within their means. And I think if we can get back to a sort of steady state where that happens, it will actually create opportunities going forward, because that sort of backup of debt had always caused ongoing problems for the system. But undoubtedly in the short term there are very real challenges, and I stick with it would be my view. Don't I know it's incredibly difficult if you're applying for jobs and you can't get the job that you want, and you have to wait. Incredibly frustrating. I've got family who are in the middle of this as well, so I do know it on a personal level. But stick with it. I think the opportunities are still there and will be realised. And I think the Secretary of State is very much aware of this. I mean, with industrial action, he said more about this in relation to resident doctors, where there have been real issues as well. But I think very much aware of this at the centre, and that it's something that we do need to resolve.
Thank you both for your responses on that one. The next one's probably for you, Adrian Whittington. The question is, it was sad to see trauma-informed approaches not included in the plan this time. It was in the previous plan. Do we know anything about why or the appetite for this moving forward? In fact, trauma wasn't mentioned at all either.
Yeah, thanks. And of course, there's two ways of reading this. One is that it was forgotten about. Another is that it's so embedded now that it doesn't need to be focused on in the same way. And it's probably somewhere in between those two things that explains this. But I think there has been fantastic sort of work at all different levels of the system driving forward trauma-informed care. And really it is something that needs to be sort of very locally embedded and driven. We've seen great work in London around this, and the London Psychological Professions Network have published a fantastic document on this. Do have a look at their part of the website. But we need to continue to drive it. And I think one of the opportunities might be the modern service framework, to make sure that it's really embedded and clear through the modern service framework that Adrian and colleagues are leading. So you may want to comment on that, Adrian, I don't know.
I think I visit lots of innovative services up and down the country, and you mentioned, I think, Adrian, the 6 pilot hubs, and those that I've had contact with, trauma informed approach is embedded in. So I think it's very true that I think in major parts of the system it's become the way things are done. I think we should still be eternally vigilant. I have to say, you still find services where they are not even aware of the concept, but I think that's the minority now. So I think it's still very much in people's thinking, even if it's not seen in a document. And the 10-year plan is really only the start. It's up to people like Adrian and myself and to make sure we take it forward and really do something with it, and work with all of you in doing that, to ensure that these things are embedded in practice across the whole of the country, wherever patients want to receive their care.
Brilliant. Thank you both for your responses. I've got another question, which is quite an interesting question, probably for Ali and Paul. So one of the colleagues who's been watching, they're quite interested to kind of hear about your experiences of physical healthcare, what it was like prior to the importance of psychological support being recognised. So yeah, we'll be kind of interested to kind of share your journey, how it's kind of changed over the years.
Thank you very much. Thank you for that question, because it is really important to service users to speak to this. So, I'm really passionate about, the change that's coming with the 3 shifts to ensure psychological care for all. You don't always experience this in healthcare, and there's also kind of dynamics around power in that space as well, which sometimes make it really difficult to speak to this. So unless that healthcare professional's been trained to have that psychological, biopsychosocial perspective, it isn't the responsibility of another specialism. It's about that being embedded in that care. So, I guess for me, not that long ago, I was experiencing, a real downturn in my physical health care. I started experiencing voice hearing, but within the context of the environment, this was missed, which ended up with a crisis escalating. I was in physical healthcare need, but I was transferred to mental health inpatient environment. Now, I think that journey for me would have been very different. There was a huge amount of distress, obviously, for the workforce and for myself experiencing this. But I think if that psychological perspective had been embedded in the training of the staff that were with me on the ward, my journey would have been really different, and I may not have needed to have gone into a mental health hospital. So, I think, it's just small things that can be noticed when people actually ask those questions. How are you doing? How are you? It doesn't have to be complex, but that awareness of people as a whole is really important to hold in mind. And yeah, trauma-informed approaches, as Adrian had spoken to as well, to be really person-centred and to really support the best possible care for individuals who are experiencing distress that can be missed, as I say, around so many factors in a busy clinical environment.
I think just on that as well, Naheem, if I can just add that, I think that we've got to get away from the fact that we think that when we go into a physical healthcare system, we can just signpost to a mental health service. And we've got to get away from the fact that when we're in waiting rooms, we've just got posters that says contact your GP, or you can do this and you can do that. It's got to go beyond and above this just a little bit more, because signposting will just, with all you guys, just create yourselves far more work. And you will, as the patient, you will just yet again go to the end of another waiting list. So it's about that integration, and I think it's exactly as Ali said, and that, we're not aware that utopia is going to exist tomorrow. We know this is going to be a hard battle, but it is that education. It is about that. How we ask people how they are. Can we just give them some digital? Can we give them some support? Can we have a, for want of a better phrase, a PWP sitting in an oncology department for when you were given the worst news that you are likely ever to have, that you have got cancer? Can you go immediately and speak to someone, have them there? This is what it's about, integration. This isn't about giving someone a poster or a phone number to ring, because that ain't going to work, I'm afraid.
And I agree totally, Paul. And I think, the evidence on the other side, I regularly attend hospital appointments with a consultant and an endocrine nurse who always ask those questions. They're always concerned. They're psychologically informed, but they are still in a position where they have to self-refer for complexity to talking therapies. But, I can see change coming, and patients will benefit and the workforce will benefit.
Thank you both for sharing those insights. Okay, Adrian, have we got time for another one? Or
I think so. Yeah. Let's do another
quick one. So there's a couple of questions related to this theme, and it's more about the balance between meeting the mental health needs, like you touched on earlier, around people living longer, the kind of multiple long-term conditions, but also balancing that against the kind of the needs and the kind of requirements of the commissioners in terms of reducing, like Adrian highlighted, around kind of reducing the deficit there is in terms of, just maybe your view on how, we can counter that, for example, the recruitment freezes, and that means kind of, the waiting list increasing.
Shall I kick us off on that? Yeah. I think this is where the 3D chess comes in. So we do need to align that need and meeting that need as well as we can with what's in policy, which includes balancing the budget. And we've got a great sort of amount to offer in that process, which is our sort of professional contribution. And that is the challenge, really. That's the challenge going forward. It's set out very clearly in the plan in Darcy before that. And I think it's the challenge of our leadership over the next years.
Just to come in there, and I think digital does have its place here. I know, again, I've seen in the chat concerns about digital exclusion. We need to make sure that nobody's excluded. And for some people, at sometimes digital isn't the way, but it can actually make sometimes the treatment, therapeutic intervention much better. For example, the ambient voice technology, where you can focus on the person in front of you. You're not having to scribble notes as you go along, which can be very disruptive in terms of forming a rapport. So I think there are things that can actually improve efficiency and improve the clinical interaction. But I think there are two things. I think we know that psychological therapies improve physical health outcomes, and we know there's good evidence, for example, of reducing length of stay in an acute hospital. So that improves outcomes, reduces length of stay, and actually frees up the system. And obviously better outcomes for patients. Who wants to be in hospital? So, and I think the other thing is that early intervention, that we know that the earlier intervene, and I think Ali, you made this point from your personal experience. If we delay things, if people can't access the care, things get worse, and it becomes more difficult to provide help for them. So early intervention, I think, is absolutely key in this space.
Thank you, everyone, for your responses on those. Thank you to everyone posting your questions. Apologies if we haven't been able to cover all the questions in the Q&A panel, but we will attempt to kind of respond to those. And they can be found on the PPN kind of website, where we're going to share the slides from this morning's session. Over to you, Adrian.
Brilliant, thank you. Well, I just want to say a huge thank you to Adrian, Ali, Paul, Naheem, also the team behind the scenes, Jacelyn, Matthew, Sam. Thank you all very much for your contributions today. It's been a fantastic session, and really enjoyed it, and really enjoyed all of your questions as well. And I will certainly have a look at those and respond to as many as possible. But most of all, I want to thank all of you who've joined today for everything that you're doing, making a huge difference to the public, making a huge difference to the people that we serve. And I think, I hope you go away with a sense that there are definitely opportunities for us to take that even further in the years ahead, and look forward to working with you on that. Thank you very much.